Well, good afternoon. It's always nice to finish up these cases and see how they're going. So I'm a regular vascular surgeon, do endo, open, and do a lot of the wound care. So it's sort of maybe sometimes a one-man show, various support, but not germane to this conversation. The objectives this afternoon are going to be talked to, do we have to revascularize? You'll see that I differentiate CLI from diabetic foot somewhat because they are different and they overlap but don't include each other completely. You've had good talks on angiosomes. I'm not going to dwell on any of this. I am going to talk a little bit about probably when best to debride and reconstruct. We heard just 2 talks ago some very nice things about follow-up and trying to figure out if wounds are healing correctly or not, and I would argue that that's probably what you really are happy to hear about and see about, and then when to amputate, that amputation isn't always the end. So to revascularize or not, just remember that critical limb ischemia, originally defined, did not include diabetic foot or diabetic disease at all, actually. And DFUs are broadly categorized into numerous groups, but about 1/3 of them are purely neuropathic. 15% are probably purely ischemic, and then a group in between is neuroischemic, but they probably behave somewhat differently than your true critical limb ischemia. And again, two speakers ago, I thought it was interesting that the one patient was diabetic and the one patient didn't seem to be, at least not profoundly, and they probably behaved a little bit differently on how they behave, in the long run. So of those patients who are actually seen in the outpatient wound center, it turns out that about 14% of patients seen in wound care in the United States are diabetic, and only about 1.5% of the patients seen are critical limb ischemic. And part of this is probably because in the wound center without revascularization, the critical limb ischemia patient is just going to do very poorly. However, about 50% of those with critical limb ischemia have some component of diabetes. So we have to be cognizant of that, and there is a large amount of overlap between these two groups. However, if we take a look at how patients do over time with happens if you don't revascularize them, and we've heard about already, that obviously the best thing to do with anybody with a low ABI or TBI or tissue perfusion pressure, TCPO2, we could spend a whole afternoon discussing which one of those might be best, as was alluded to. But the patients who have critical limb ischemia, when not revascularized, you can still heal a group of them, about 50% of them over a period of a year, or even with a minor amputation. And Bill Marston's group obviously showed that good wound care in patients with lower extremity ulcerations with poor perfusion did not do as well, but they did okay. And we've also shown, actually in our group, that percutaneous revascularization speeds the healing trajectory. So obviously, helping to revascularize patients is paramount, but you don't have to revascularize everybody. So even if you have an unsuccessful attempt in marginal ischemia, these patients can behave very differently. Now, we've also heard earlier today about angiosomes, and we can beat that up forever. But so my PTA atherectomy stent was successful. Well, that's very nice, but in this one particular study, that we look at here, what you're going to see is that there was a 96% success rate, but there's still a 12% 30-day major limb event. So obviously, just leaving the suite is not the imperative. And I would agree with previous speakers that although follow-up testing is nice, really how the wound is doing is nice, and this may speak to the angiosome that you have revascularized. And it probably doesn't matter, or it does matter, which technique you use. And when I say which technique, I'm not talking about Safari versus antegrade versus this or that. I'm talking about endo or, sacrilege here, but open surgery, because they do behave differently. The one study taking a look, retrospective study from Europe, taking a look at 349 ischemic wounds showed that about 50% of them have a somewhat ambiguous angiosome, so fairly hard to tell. The ambiguity of stratification into angiosomes was highest in the heel, Achilles, in the upper leg, lateral, medial, malleolar, so a lot of areas of the foot. Actually lowest in the malleolar wounds overall. So which angiosome to fix can be a real problem. The take home on that is if you go through all the data, and I didn't want to bore people with more data after an entire day of it, so I'm just going to give you my distilling of this, especially since time is limited. But does the choice matter? And we know from Basel and Best and et cetera, you know, the reality is bypass and percutaneous intervention are not or should not be really competitors. I don't think it makes sense to make them competitors. They are adjuncts to each other. We know that bypass on the left-hand side here has worse early outcomes, patients do poorly, fewer reinterventions though, and better long-term survival it seems, but no real difference in limb salvage rates, whereas angiosome concept matters a lot more. So for the endovascular specialist, if you're dealing with a forefoot lesion, you really need to get that dorsalis pedis open, and if you're dealing with a posterior foot lesion, you need to do something with the posterior tibial. If you really can't get that open, you know, percutaneous interventions of the perineal, I mean, I did one last Thursday for a forefoot lesion, and he doesn't have any other targets in his foot, and I didn't try to reopen his dorsalis pedis, but the reality is that you do get more volume of flow through a bypass, and a bypass to this gentleman's perineal vessel would probably be more likely to heal his forefoot than an angioplasty of it. So in general, if you start off with a wound and an angiosome that you can kind of determine, revascularize that angiosome at all costs. And if you're successful, then to ensure that revascularization, by a week or 2 weeks out, you can start to debride that wound, rebuild it, use tissue, et cetera, which I'll talk about in just a moment since that's the nature of this talk. But when you can't get that angiosome open and you can get a different target in the foot, there's something still there, bypass to the best distal target. And for a person who is taking care of those wounds, this actually makes a difference. The other thing is endovascular first. Well, we certainly practice that, but in general, that's not always the case. In some places you may really want to think about that is patients who have end-stage renal disease and patients with very large amounts of tissue loss, because these patients tend to heal much better with bypasses and much quicker. And it was also alluded to, you only have so long to get these patients healed. So I'd say that endovascular first is in general the right concept, but at times with select patients with select comorbidities, not actually the right thing to do. So when to debride and reconstruct after that revascularization? Well, if the limb is gangrenous, and this is something that Stephen and I debate to some degree, I think, at various places. He keeps inviting me back to Asia to come over and talk to him about when to do this. But in general, if there's a wet gangrene, debride it early on, maybe before the endovascular procedure or revascularization. If it's dry gangrene, you can certainly wait. The thing to remember is that after a successful bypass, it takes 4 to 10 days to maximize the peri-wound TCPO2. And that might even be, you know, a little bit longer than that. And I would say that there's starting to be some data, despite what was shown just previously, but the tissue perfusion pressure probably is a better indicator of healing, although it can be hard to get. But again, you have about 10 days maybe you should do a definitive reconstruction. So we're really talking about starting to use reconstructive options, but you should wait about 10 days after angioplasty. I'm sorry, after bypass. But after angioplasty, it may take 30 days. So you can expect maybe a little bit slower progression after that angioplasty is performed. And I think you have to keep that in mind. So debriding and reconstruction should probably wait 1 to 2 weeks till you really start to get a sense. When salvaging toes, it's nice to just let the tissue marginate. The heel ulcers, you can take them to the OR if they develop signs of early sepsis, but you can also let those marginate for about 2 weeks or so. Source control is important, so if a patient does have wet ischemia type of thing or wet gangrene, they probably should be debrided prior to revascularization, because after revascularization, if you're successful, you can actually make them quite sick. So they're somewhat busy looking over here, but with the angiosome sort of guided reconstruction, if you have successful inline direct revascularization, you can consider a flap versus a cellular tissue-based therapy. So you could possibly do a small rotational flap, which aren't too hard to do, and have this done if you have good perfusion to that angiosome. And as something that Stephen and I have talked about before, you know, if you can get 3 to 6 months out of this, you'll get that flap to heal. Because the thing that's nice with a flap is a single operation, and you have to remember most foot operations for these patients are going to take up to three unsuccessful attempts or 3 repeat surgeries. If you have successful indirect revascularization, you're going to want to think about using a cellular tissue-based therapy. You're not going to do a flap, and this is usually going to be a staged procedure that will take 2 or 3 procedures, possibly 1 or 2 of those in the OR. You can also do that if you have no success and you have an ankle brachial index that's between 0.5 and 0.7. But if you have no success and you have have an ankle brachial index less than 0.5, you probably should just go with conservative debridement and sort of standard of care without much in the way of advanced therapies. So finally, what about amputation? Well, amputation considerations are subject's comorbidities. You know, she's had one above knee amputation, her forefoot looks like this, and the reality is, should I spend a lot of time trying to revascularize her left leg? It will help her to pivot and such, but the reality of how she would do with this has to be considered. We already saw this data actually in the previous speaker's talk, but this is a look at the data from this year of 662 patients. 100 of these patients were not revascularized. And as alluded to, the all-comer mortality was 33% at 1 year, but the other mortality was actually 50% when these were age matched. So the patients who did not undergo revascularization had a 50% mortality, but when matched the patients who did undergo revascularization but had the same comorbidities, again, approximately a 50% mortality, and their 1 year limb salvage was not ideal. We do know who does badly with PVI, and those are patients with dialysis, emergency procedures, age greater than 80 years. And I think we have to take this into consideration. We actually are putting most of our patients into the WIFI score and using this as an unsalvageable foot versus amputation versus low-risk amputation, and trying to use this, and I think this is a fairly validated and actually fairly easy system to use. But one should keep in mind that the 30-day mortality, when you take a look at all three of these types of procedures, endovascular versus open versus amputation, even in retrospective series, tends to be roughly the same. And so I think a lot of us are taking the approach of why not try an endovascular procedure and then go on to possibly this final amputation. So in closing, to think first, is the patient ambulatory? This is a predictor of, are they going to do well with a percutaneous intervention? Do they live at home? Are they on dialysis? Are they demented? And how bad is their CHF? Remember that for limb salvage, a lot of these patients are going to have to undergo 3 more operations in their lower extremity for absolute limb salvage. Thank you very much.